progression in glaucoma. Thank you for your kind attention. A very good evening to each and everyone here, and I welcome you all on.
So what we have seen now is the evaluation of the functional progression. So we will now see the pitfalls in interpretation of progression in visual fields, which will be by Dr. Shalini Mohan.
Thank you, Dr. Subhashini. Good evening, everyone. At the outset, I would thank Dr. Ankur Sinha for having me here for this IC. Now, just now we saw that how to assess the progression. Now, it is important to assess the pitfalls in progression because on the basis of that, we need to decide the treatment modality for our patients. We know that visual field progression is very important and challenging aspects of glaucoma management because it influences the critical care of our patient and also is used as an endpoint in many of the clinical trials. So, the question to house is, which is the most common method to judge progression? What you use generally, what we all use generally is that we keep all the fields of the patient in series, one after the other, and try to assess the progression, and then start Googling our eyes. So the thing is that, is it the right method? Can we actually judge progression by this method? The answer is no. Because there are two important factors which we need to consider. First and foremost is that there is a normal visual decay which happens with every individual as the age advances. So there is a kind of progression and there is depression in visual fields of around 0.07 decibels per year. Now this depression is common in glaucoma patients and it is around 0.6 decibels per year in the patients who are being treated for glaucoma. The patients who are not being treated, this mean rate of progression is around 1.1 decibels per year. Another important factor which is there is about fluctuation. That means that there is a short-term fluctuation, that can be a long-term fluctuation, and also there can be a test-retest variability which needs to be considered whenever we are actually doing the visual fields for our patients. Now this was a study which was done on 51 subjects in which every week visual field was done for 4 weeks. And what was seen was that whenever any depressed point were near to fixation, there were more test-retest fluctuation. Now, as we can see in this graph, if the depression is around 0 decibel, the fluctuation was from +3 decibels to -7 decibels. Similarly, if fluctuations were near to -10 decibels, then the retest variability was -1 to -16. Moreover, whenever just now we saw in the talk of Dr. Ankur also, whenever there are peripheral points which are being assessed, there is more test-retest variability. So these things needs to be considered whenever we are assessing progression. And if we don't consider these things, then we are likely to miss something important. Now, to establish a valid progression, it is important to have at least 6 visual fields in 2 years' time. Then only we can get exact rate of progression, and accordingly we can modify our treatment. So we saw just now the overview printout, which has got the grayscale, the data, the total deviation plot, and the pattern deviation plot. Now, on the basis of this, we can see that yes, the patient is progressing. Like here, we can see there is no scotoma, but then there is a scotoma in the inferior part of the visual field, and we can see it is enlarging. But the thing is that whenever we are seeing like this, we also focus more on mean deviation. Now here we can see the mean deviation here is -3.7, and similarly it is increasing in negative values. So, but there is no statistical analysis and we cannot detect the rate of progression. So how should we identify in such a scenario? Now, whenever there is appearance of a new defect, it is important to apply these important parameters to assess the progression. whenever there is a cluster of 3 or more non-H point, each of which declines by more than 5 decibels than the baseline, this is an important criteria to assess progression. Another criteria is that if there is a single non-H point which has gone depressed by more than 10 decibels, or a cluster of 3 or more non-H points, each of which has declined by less than 5% levels. So we know that now the new defect is there for the patient, and that means he has progressed. Now this is important that this should be on 2 consecutive fields. Another important thing is that if there is deepening of a pre-existing defect. So when do we call it as deepening? We say that whenever a defect has enlarged by 2 or more points within or adjacent to an existing scotoma. So there should be a scotoma around which there are 2 or more points which have worsened by 10 decibels. That means that it has progressed. Now, we saw that there can be an event-based progression where event has happened. So we take 2 baseline visual fields, and from 2 baseline visual field, the particular field of the patient is compared, and whatever changes are there, that is actually given in the form of GPA printout, and that is the event-based analysis. The another one is trend-based analysis. That means we are following the patient throughout the time duration, and that is given in the form of trend-based analysis. So we realize that the most important thing in both these analyses is to establish the baseline. So what is the baseline visual field? That means patient should have 2 consecutive visual fields which should be extremely reliable, and then only we can compare from these baseline visual fields to other visual fields, and then only we can say that yes, the patient has progressed. So this is about the event-based analysis, where these are first 2 baseline visual fields and by which rest of the fields are being compared. So whenever there is a comparison, if there is a depression in one field at one point of time, this is an open triangle. If the depression is seen on 2 consecutive visual fields, this is an half open triangle. And if it is on 3 consecutive visual fields, it is a closed or the dark triangle. So now here we can see the GPA printout, and if we see this glaucoma probability map closely, these are the areas where we can see the open triangles or the closed triangles or the half triangles, and we can see the message lower down that there is a likely progression. Now, if we don't establish a proper baseline visual field, then obviously the comparison will not be proper, and then we tend to miss certain things. Now here we can see the GPA printout, and again a message of possible progression and likely progression. Now this GPA printout I wanted to show because if we see in the first printout here, we can see there is an superior arcuate scotoma, and in the next one, there is sudden depression of visual field and almost whole of the visual field is gone. And so we examined the optic nerve head of the patient, and what we saw is that optic nerve head of the patient was not actually that progress. So what was the problem? So we explained the patient again, we made him comfortable, and then again the fields were repeated, and this was the thing what we got. So the thing is that many a times the patient is tired, the patient is fatigued, he is not able to perform as he should have been, and at that time there are likelihood of problems, and that might confuse the clinician that there is a progression, but actually that is not. Now coming to another thing, that here we can see this is a visual field of a patient in which we wanted to establish baseline. Now you can see that there are large amount of fluctuation problems in the upper part, almost 9/20, it is double flagged. So we tried to do another visual field for the patient. So it was not just 1 or 2, we had to do series of visual field. You can see 1, 2, 3, 4 and 5. So it is not that the patient's visual fields are improving. If you see the first one and if you see the last one, how good they are looking. It is not that they were improving, but it is actually that there were so much of losses, fixation losses you can see everywhere except in the last field. So it is not that patient was improving, but actually patient was learning. Because visual fields is a difficult test to perform. Even when we are performing, it is not very easy to capture each and every light what we are seeing. So it is a difficult test, and that is why many a times patient needs to be explained that yes, there is a problem. Now coming to trend-based analysis in visual field, which is another very important to assess the rate of progression which is given in trend analysis. Now if we enlarge this graph, and we see that first two are the baseline visual fields as we always establish. Now if you see the next one, it is looking depressed, but another visual field is looking a bit improved. So the thing is that if we see this graph, patient is looking almost stable. But what is happening over a period of time, that is what trend-based analysis says. Now, over a period of time, you see that yes, patient is gradually and slowly progressing, and this is the rate of progression which has been given by trend analysis. So this is the problem with event-based analysis, that if you compare with just one visual field, you're likely to miss something which we can get in trend-based analysis. Now, this is another very interesting patient. If we see the baseline visual field here, these two are baseline visual field, and look how rapidly the patient started progressing. So here, and then suddenly, at here, you can see all these clusters of visual field, they are almost stable. So what has happened? Actually, when the patient started progressing so fast, then there was an intervention which was done. So surgery was done for the patient, and again the visual field, they became stable. So now in this particular patient, if we see this graph, this is progressing so fast, and it is giving an impression that this patient will become blind in due course of time. So here what should we do? We need to re-establish the baseline. Now once you have modified your treatment here, then you change your baseline visual field. Now these two visual fields are the baseline after you have modified your treatment. So you have modified here the treatment, and now look, the patient looks stable. And if you can trace this graph, patient is not there is no likelihood of patient getting blind. So sometimes you need to re-establish the baseline, and you need to change the baseline to get the exact value of progression. Can I take 1 or 2 minutes more, ma'am? Thank you. So there are other challenges also which we face while dealing with these progression. Now like in this, if you see the pupillary size was just 2 millimeter, and see how depressed the fields are looking. And when the patient was dilated with 3 to 4 millimeter size, the visual field improved. So you must look after the pupillary size also. It should be normal. Similarly, again, this is a meiotic pupil, and this is a normal pupillary size. They can be problem with dilated pupils also. So this was a study also which was published in 2020. Now here we can see this is the dilated pupil, and this is a normal pupil. So if you have done the pupillary examination with dilated pupil, that means at every examination you have to do dilated visual fields. So that is very difficult. So always try that whenever patient is coming for the visual field, the pupils should be of normal size. Now this is, I will skip that. I will move on to this. Now here we can see this particular patient, that there was a increased scotoma in the patient who was regularly following with us. And then again, we explained the patient, and look how it has improved. This is corresponding central defect corresponding to his cataract. So sometimes we need to give few more extra time to our patient explaining about the problem. Now here we can see now this particular patient in which this was a regular follow-up and following patient with us, and we can see that there was a scotoma here in the superior and the inferior part of the visual field. But again, the visual field was repeated, and he had this deepened scotoma. And when we look at the disc, it was looking absolutely non-glaucomatous. So in such scenario, what to do? Again, the patient was explained the procedure, it was repeated, and it improved. So Now coming to another very interesting case, this was a glaucoma patient. Now we can see the right eye of the patient, which was almost normal. In the left eye showed inferior scotoma, and he was doing pretty well. One day he said, I am having too much of vision loss and I am having problem, madam. And we repeated the visual fields, and this was the scenario. You can see there was a right defect and there was a left defect, and this was the inferior arcuate scotoma, which patient already had. So we can see that this particular visual field is following the vertical meridian. And we can see there is a kind of homonymous hemianopia in both parts of the visual field. So even if patient is glaucomatous, that doesn't mean that he might not have any neurological problem. So whenever you have a field defect with vertical meridian, don't think about progression. It can be neurological. And we did the imaging. There was a pineal gland carcinoma, which was then further taken up by neurosurgeon. Now coming to another very important thing, like media opacities, cataract, as I said. Once you remove the cataract after surgery, you can see there is improvement in the visual field. Now here, it was with cataract. You can see the total deviation plot, which is completely blind. And here you can see the total deviation plot has improved after cataract surgery. So again, that means you need to reestablish the baseline visual fields for this particular patient to assess the progression. Now, this patient was another interesting case who was following with us, and he was non-glaucomatous, and but there was a family history of glaucoma. So he was getting his visual fields, and although discs were around 0.6, not too much of cupping, and there was no notch, etc. Now, one day he came with this kind of visual field, and so sudden appearance of any scotoma should actually raise your tentacles, you raise your eyebrows, that this is not progression, this has to be something else. So we dilated the patient, and what we found was there was a large BRVO in this particular patient. The thing is that always examine the fundus whenever you are suspecting something more than simple progression.
Can we wind up?
Yeah, sure. So this was retinitis pigmentosa. There can be artifacts. So the take-home message is that timely detection of progression is very, very crucial, because you have to modify your treatment. But always use your clinical judgment and always correlate with your fundus finding. Thank you so much for your kind attention.
Thank you, Dr. Shalini, for those detailed explanation of the challenges in interpretation of visual fields. So we'll move on to the next talk by Dr.